Hello everybody, hope you all are excited for this video. Yes, the topic which I've chosen here is that it is the chest X-ray interpretation. Well, this may sound so weird. Why do we need to know about the chest X-ray? Yes, being as a nurse, we need to read the chest X-ray as soon as we receive from the patient side. Thereby, you can come to some certain conclusions on how we can position the patient. Might be it is a simple procedure such as the postural drainage, or might be you're going to place the patient in position. Might be a semi-fowler or prone or lateral or right. So depending upon the chest X-ray findings, you may be able to find or guess out on how the management can be started. So yes, let's get started with the new topic which is very unique as well as very enthusiastic to know more on chest X-ray. Yes, not wasting the time, let me go into the session. So before going into the how to read upon a chest X-ray, being a nurse, we need to know on how the quality of the image looks like. So in order to assess the quality of the image of the X-ray film, just we have a mnemonic called as RIPE. That is, R stands for rotation, I stands for inspiration, P stands for projection, and E stands for exposure. Well, I know you all are now excited on what is rotation, inspiration, projection, and exposure. Let me explain in detail one by one, starting from R, which is rotation. So the rotation is nothing but it is just giving us an idea. So when you see the chest X-ray, the vertebral bodies that is which is just behind the that is you can see a red line marked over here. So when you have a light source or when you place it on the light images on the X-ray film, you can see that you can easily find out the vertebral bodies from the antero to the posterior. And the spinous process should be arranged in a fashion that they are all vertically arranged, well, well sequentially arranged. So here you can see the spinous process here and one here, one here. So likewise, you must be able to easily see through the X-ray film the spinous process as well as the vertebral bodies. And next important thing which we have to know how the rotation is being present is that you can directly go on and deeply see on the spinous process which is very like located in between both the medial clavicle. So the clavicle bone also must be easily visualized in a chest X-ray as well. Just between the clavicle bone you have the spinous process. So the medial aspect of each clavicle should be of equidistance from the spinous process. So from the spinous process, when you draw an imaginary line, it should be of both the equal distance. That is 2 centimeters away from the spinous process to the right as well as 2 centimeters away from the spinous process towards the medial left clavicle. I. So I stands for inspiration. So while capturing the image, the patient is always asked to inspire and hold the breath to visualize the anatomical position more clearly. So as a nurse, when you are visualizing the chest X-ray, you should be able to visualize 5 to 6 anterior ribs as well as the posterior through the posterior ribs. So these blue well-defined marks is showing the anterior ribs. Even in the other side, you can see the anterior ribs, how it's passing in such a fashion. And if it is like you're able to see both the anterior and the posterior ribs like a thoracic cage, then like the patient has done a good proper inspiration. So we all know that while taking the chest X-ray, the X-ray technician says the patient to have a deep inspiration, hold the breath, so that both the lung is easily inflamed and you can see all the findings. And as well, you must be able to see both the lung apices on the top as well as the costophrenic angle, which is very close below. So the red mark, or let's show it another color. So this is your costophrenic angles very close to the diaphragm and the lateral surfaces of the ribs. And as well as you must be able to clearly define, or you must be able to clearly see the lateral ribs. So this is the green color which I'm drawing is the lateral rib. So this is how on inspiration when you do the chest x-ray, then it is a clear image and you can go in further into the details of how the lung as well as the cardiac is being placed in the diaphragm as well as the costophrenic angle, and you can also see the other deformities in the chest x-ray. So P, as I told you, right, P stands for projection. So it's a unique one that standard X-ray is always from the posterior anterior projection, which is the beams of the X-ray beam is coming from the beam posteriorly towards the anterior surfaces, and the X-ray beam is being projected from posterior to anterior surface before reaching the detector. And in case of an AP view, you can see it is vice versa. So the X-ray which is on the top is denoting the PA view, and the X-ray which is at the lower segment, it's denoting the AP view. So in AP view, it's not that much the patient is not able to mobilize or he is not doing the maneuvers when we are seeing. So in this, you are not able to clearly define of what the chest X-ray looks like. So might be the patient may need a repeat X-ray. So always a PA view is very, very essential to read or to depict the cardiac as well as the other lung prominent fields. So how we can distinguish, yes, whether it is a PA view or AP image. So if it is PH, it is standing denoting posterior anterior view. The other one is anterior posterior view. So in this PA view, you can easily see the size of the cardiac size. In case of AP view, the cardiac size is always exaggerated. Might be if the patient is having a normal cardiac size, but still due to the AP image, it may predict like it is a cardiomegaly, but actually it is not a cardiomegaly. As well, you can also see the edges of the scapula are often visualized in the lung fields in an AP film. And E stands for exposure. So exposure, this is mostly important to allow the visual fields of the visualization of the pulmonary veins. By here I have marked the blue one, where you can see the pulmonary fields as well as the pulmonary knuckles, where the aortic knuckle and the aortic window. So all details you can see in a exposure. So here the pulmonary vessels, the lung fields and the bone anatomy also we can easily visualize through this chest X-ray. In case if it is overexposed films are always appearing very much darker, and the bones in the heart is not seen, and the lung and the pulmonary artery is not able to be easily detected in case of overexposed films. And in case of underexposed films, the film appear much white in color, and it makes very difficult in visualization of the retrocardiac region as well as the spinal anatomy is becoming more difficult. And as well, not only we are going to see the cardiac as well as the pulmonary veins, the lung fields. We also visualize in deep on the exposure of the left hemidiaphragm where I have marked the blue one. So it should be easily visible as well as to the spine and the vertebra is easily visualized behind the heart. So this denotes that it's like a good exposure of a ray of beam has been presented to the patient. So yes, not delaying much more, we are going into the ABCD approach and how to read a chest X-ray. So far we were just seeing whether the chest X-ray was done in a good sequence or is it due to any other alterations where the chest X-ray is either underexposed or overexposed. Now we are going to see about how the ABCD approach works on a patient to read the chest X-ray. So A stands for airway, B stands for breathing, C stands for cardiac, D stands for diaphragm, and E stands for everything else. Yes. So A, you'll be seeing the airway which is starting from the trachea, carina, bronchi and the hilar structures. And B stands for the lung and the pleural spaces. C here the cardiac, where we are going to see about the cardiac size as well as the borders of the right and the left. And D stands for diaphragm, where we are going to see the diaphragm where it is being present, whether it is compressed or elevated, as well as we'll be going into depth of the costophrenic angles, which is very close to the lateral borders of the thoracic cage. And E stands for everything else, that is the mediastinal contours, bones, soft tissues, as well as the tubes, valves, pacemakers, and review areas. We'll be much concentrating on whatever else is present all over the chest X-ray. Starting from A is where I told you the airway. So the airway which starts on from this, so here you can see the picture which is denoting the trachea, very well seen. And then C is like in the airway you also see for the Carina space and the bronchi, the left and the right bronchi which is dividing, and of course the hilar structures, that the left and the right hilar structures. And here the airway, that is the trachea, can go for deviation. So here we can define into two major deviation, that is the true deviation. The other one might be due to the patient being rotated in the bed, having an apparent deviation. True deviation is mostly of pathological origin, and it is always seen in a case of a large pleural effusion or tension pneumothorax or lobar collapse. In large pleural effusion and tension pneumothorax, always the trachea deviates from the site of pathology. Like for example, if the patient is having the right side problem, the lung issues, it will be deviated towards the left. Very well, clearly listen. So if the patient is having a right lung problem, the trachea is being deviated towards the left. And in case of a lobar collapse, the trachea will be pulled towards the site of collapse. In the sense, it's explaining that it is well defining that the pathological site will be of the changes where you can see. So that we call it as the trachea getting pulled towards the affected area. So in this picture you can see the hilar image, the right and the left, and this image is denoting that there can be some sort of sarcoidosis due to inhalation of asbestosis. The patient is having large changes in the hilarial region, or in case of mesothelioma, a condition where due to inhalation of asbestosis, the patient is having these changes. That is, you can see the fine white patches around the right and the left hilar region. And then on the other side, you can see that it's a unilateral change in the left side, which is denoting that there might be a space occupying tumor around the lung in the left side. So now coming to the breathing. So the breathing here, you can see that you're going to see the full lung spaces, how it is located from the costophrenic angle, the hemidiaphragm, as well as the apices of the lung, as well as we're going to see on the outer layer of the coverage of the lung, which is we call it as the pleural space. So here you can divide the zones of the lobes as right upper zone and right middle zone, right lower zone. Similarly on the left, such as left upper zone, left middle zone, and left lower zone. In case of a pulmonary edema, consolidation, or in case of any malignancies or pneumothorax, these zones are highly located and highly specified, that there can be a uniform changes due to the pathological condition. So coming to the breathing, starting from pulmonary edema. So this X-ray picture is actually depicting us on the airspace opacification, which is like bat-like wing being present on both the sides, as well as you can see the curly beak lines, pleural effusion on the sides, that is on the pleural space. And you can also see the costophrenic angle is blunting. So here then on the left side, the yellow mark which I am showing over here, there you can't see the costophrenic angle itself. There is a big blunt over there where that is indicating that there is a large amount of pleural fluid which is being occupied in the left lung, as well as fluid in the interlobular fissures. So all these regions you can see. And this picture, X-ray picture, is actually depicting the consolidation. So the consolidation is present over here on the right lung with horizontal fissures. You can see the fissures are very like a pattern of like the ribs itself, and this is mostly seen in case of a pneumonia. This X-ray picture is denoting primary pneumothorax, which is present on the right side, and then the secondary pneumothorax, which is present on the left side. You can see the dark still outs of the lung and the pleura. So here the pleural space which we are going to see is that normally the pleural space are not thickened, but in case of a disease condition such as mesothelioma or might be hydrothorax, hemothorax, empyema or pleural plaques, you can see the missing of the angle, that is the costovertebral angle. Next, coming to the C, which stands for cardiac. So here in cardiac, we're going to see the cardiac size as well as the cardiac borders. So when you draw an imaginary line from the lateral surfaces from right to left and the cardiac borders from right to left, always it should be of less than 50% of the thoracic window. In case if it is more than the 50% of the thoracic window, which indicates that the patient is having cardiomegaly. And this cardiomegaly is always seen in case of a patient with right heart failure or left heart failure, or might be in case of congestive cardiac failures, as well as the borders. So in the borders you'll be seeing the left and the right. So in right borders, mostly you can see 50% of the right atrium you are able to visualize, and on the left you can see the left ventricle is taking a major portion, the left heart border. Coming to the diaphragm, so the diaphragm, the right and the left hemidiaphragm, you can see the costophrenic angles ending with the lateral. And in case, always in all the patients, you can see that the right diaphragm is always higher than the left because of the occupied liver which is present on the right upper quadrant, and as well as you can see in the left upper quadrant, due to the presence of the stomach epigastric region, there you can see the gastric bubbles in and around the chest X-ray, which is a normal finding. And this finding is actually an abnormal. As I told you, always the right diaphragm is higher when compared to the left. But in this case, you can see that the diaphragm is very pictured out, and there is a space between the diaphragm and the liver, which is stating that there might be a sudden perforation in the bowel. As well as you can see the gastric bubbles being distended just above the costophrenic angle of the left. And as I told you, we will be seeing also the costophrenic blunting. So in this picture you can see the costophrenic angle is not at all visualized when compared to the left, and mostly this is seen in a case of a pleural effusion or consolidation, or might be in case of hyperinflated lungs such as COPD or asthma. And last but not the least, everything else you're going to see about the ECG leads, whether the patient is being clipped onto the ECG leads, the patient is being fixed onto the pacemakers, or might be the last picture which is denoting the presence of NG tube into the gastric region. Hope you all enjoyed the video, and your insights on chest X-ray is now very well known to you. Hope you all are clear on how to distinguish a normal X-ray and an abnormal X-ray, and hope you all enjoy the video today. Thank you for your patient listening. Don't forget to subscribe and pass on the link to your friends so that they may also get utilized. Please do give your suggestions as well as your doubts and the queries in the comment box, so that we'll be making this session more video in the future classes. Thank you.